Good morning and welcome to Cardiology Grand Rounds. I have to say, this morning's going to be one of those special Grand Rounds because ordinarily the speakers we have coming in, we give them, 6 months notice. They get to go through every iteration. They're presenting it all around. This morning's speaker, Dr. Neda Dianati-Maleki, I think I gave her about 18 seconds. And the presentation looks spectacular. I think as everybody realizes, we're going to be moving over to the high sensitivity troponin as an institutional standard. And to say that it has its nuances is a little bit of an understatement. And so this morning's Grand Rounds will be Dr. Dianati-Maleki, the head of our consult service, actually explaining a little bit of how we intend to roll it out and what it's supposed to mean to everybody. And you can imagine it's a pretty diverse population of providers who are going to be looking at these test results and trying to figure out what to do. This morning, Grand Round speaker, Dr. Neda Dianati-Maleki, went to medical school at the Iran University of Medical Sciences and Health Services in Tehran, where she met Hali's finest, Dr. Arash at the Shami Afshar. They got married upon graduation from medical school and then moved to Edmonton, Alberta, where she received her master's in clinical epidemiology from the University of Alberta School of Public Health. There, she also worked with Dr. Paul Armstrong, who I'm sure all of the cardiologists in our group is affectionately known as the Eugene Brunwald or Valentine Fuster of Canada. With Arash, she performed her internal medicine residency at Mount Sinai St. Luke's, Mount Sinai West. And then we were fortunate to match both of them to Stony Brook Cardiology's fellowship program. This was followed by an imaging fellowship under Dr. Smadar Court before we were also able to recruit her to our cardiology faculty last year. Dr. Dianati-Maleki has been an outstanding faculty leader, directing and revamping our inpatient consultation service while being an integral member of our structural heart and non-invasive imaging programs. Moreover, she is rapidly becoming a destination cardiologist for second opinions in our outpatient settings. So please join me in welcoming Dr. Neda Dianati-Maleki.
Well, thank you for that very kind introduction. Good morning, everyone, and welcome to our Cardiology Grand Rounds. I'm going to share my screen now. Maybe screen number 2. Okay, very good. So good morning again. Thank you and welcome to our Grand Rounds. We are very excited to announce our institution's transition to high sensitivity assay. And we expect to launch and go live sometime next month, just within a few weeks, I believe in mid-February. This has been a big project requiring a lot of a great team effort by a very fine group of people across the board, from clinical laboratories, IT, the ED emergency medicine leadership, and of course, the Division of Cardiology. And I would like to thank them all for their leadership commitments to get us to this point where we are ready to launch. High sensitivity troponin, as you know, is quickly turning into the standard of care, and it has been recommended by many societies, guidelines, consensus documents as the preferred method for assessment of patients with ACS and for diagnosing of acute MI. Our colleagues across the pond in Europe made a transition about more than a decade ago. And the results, based on their published literature, have been nothing less than full success. They report great rule-out capabilities, shorter ER, length of stay, and a very low miss rate using these assays. We would also like to replicate that success here in the U.S. and here at Stony Brook. And we appreciate that. We need to educate our clinicians about the features, the analytical features of this test, and what's the best practices to use it to assess our patients with ACS. And that is going to be the purpose of this talk. I have no disclosures. So at the end of this talk, I would like everyone to be able to be familiar more with the advantages and why we are making the transition. What are the advantages of the high sensitivity assays compared to the current conventional fourth gen assays? We want to make sure all the clinicians across the board are comfortable differentiating acute myocardial injury from an acute MI, and they're able to diagnose acute MI based on the new assay. And of course, we want everyone to be able to comfortably interpret and document elevated troponin levels when it's not due to an acute myocardial infarction. So in order to take a look at the evolution of serial troponin testing, there was not a time not too long ago where we had to wait 18 hours to diagnose an MI, whereas now we can detect the troponin release from injured cardiomyocyte within minutes, and that is amazing. So the new assays, why are we even transitioning? They're extremely sensitive, which means they detect very low levels of troponin in the circulation. In addition to that, they're highly precise. They measure what they're supposed to measure, and that increases the diagnostic accuracy. The principles of epidemiology 101 teaches us that high sensitivity translates into great negative predictive value, and that is the whole purpose of applying these tests. They allow us to use rapid chest pain algorithms or accelerated algorithms to assess, to risk stratify ACS patients in the ED, and to use it to quickly for rapid rule in, rule out of patients, which of course facilitates the triaging these patients, especially and in particular in the emergency departments. We here at Stony Brook are planning to transition to use a troponin T assay. This is a 5th generation high sensitivity troponin T assay by Roche, which was FDA approved in 2017, one of the first assays to be FDA approved. By definition, high sensitivity assays have to be able to detect some levels of troponin in 50% of asymptomatic healthy individuals, and this assay passed that test. So it was approved by FDA in 2017. It is extremely sensitive and very highly precise. It has the fastest turnaround time among all other assays and resolves the troponin within about 9 minutes. And it has the unique feature of providing standardized sex-specific cutoffs for us. So we'll get different cutoffs for men and women. So this is an important slide. First, what happens after the transition? We are expecting a change in the reporting unit. Currently, with the conventional 4th gen assay, we are using nanogram per ml, which leads to all these tiny little numbers, 0.01, 0.02. But with switching to a nanogram per liter unit, we're going to be reporting whole numbers without decimals, which is going to make it a lot easier to communicate the values. In a study of about 1,600 healthy individuals, the 99th percentile upper reference range for this assay was determined to be 14 for women and 22 for men. The critical value that is going to be flagged by a lab currently is 0.03 with the 4th generation conventional assay. Going forward with the high sensitivity assay, that is going to be 52. So 52 and 0.03 are sort of equivalent, okay? So this is a number we want to learn and remember. The measuring range currently is 0.01 to 25, but it's going to start from 6. And 6 is the level of quantification for this assay. FDA, the assay is able to measure lower levels of troponin, but this is the level that FDA allows us to report, the lowest level that is allowable to be reported. So we're going to see troponins ranging from 6 to up to thousands, up to 10,000. Okay, so that's going to be our measuring range with the new assay going forward. This is another important table that I want you to try to sort of learn, and it helps you kind of translate the values of troponin between the two assays, the conventional 4th generation that we're currently using and the 5th high sensitivity assay that we are going to launch in a couple of weeks. And as you see, a value of 0.01 is going to be somewhere around 30s. a value of 0.03, which is going to be flagged by the lab as abnormal. It's something around 50, it's 52. And 0.1 is a value, is an important value that in literature has been described as an anchor value, which our positive predictive value somehow gets, significant and gets serious. And when we see this value of troponin, we sort of think that this could be a real event, a real ischemic event, and that is going to be equivalent to around 100 to 150. So this is a value, this is a number you want to remember. And going forward, in order to, we do expect, and this has been described by other colleagues who already have made the transition, that initially there is going to be sort of a psychological shock because of, since we're going to see a lot larger, a lot bigger troponin values. And sort of having this table in mind and being able to translate back and forth sort of has been, shown to help us sort of curb and tackle that psychological shock. This next figure also compares the values of fourth generation troponin T with the fifth generation. And again, as you see, 0.01 is equivalent to around 30, 0.03 to 52, 0.1 to about 100, 150, and so forth. And I want you to pay attention to this gray zone. This is the area where with the conventional assay, it's going to be reported as completely negative. We are expecting to see a lot of patients having measurable troponins in this range. And we know that the majority of those values are not going to be due to an acute MI. Well, with the new assay, we're going to detect a lot of myocardial injuries that are not due to an acute MI, that are not ischemic. They may be due to structural heart disease, may be due to renal failure, and they fall in this gray zone. And just knowing that with the conventional assay, these would be considered negative sort of gives us a reassurance to know the majority of these are definitely not going to be due to an acute MI. Another important concept, which is really not new, and we already subconsciously take it into consideration when we interpret a series of troponin levels, is the delta. Delta, or the change or the rate of rise between consecutive troponin levels, is an important concept going forward in the high sensitivity troponin era. Whenever you have an elevated troponin, if you can demonstrate with serial sampling an acute rise or fall pattern or a significant delta, that is, going to tell you that you are dealing with a case of acute myocardial injury. This is acute. In the absence of that acute rise or fall pattern, what you're dealing with is just a chronic myocardial injury in the case of ESRD, structural heart disease, and many other conditions. So demonstrating that acute rise or fall pattern is very critical in interpreting high sensitivity troponin values going forward. This is an important figure, and I want to invite you to pay attention to it. So, on the y-axis, we're seeing the cardiac troponin levels, and on the x-axis, we see the time from symptom onset in hours. The green line on the bottom shows the 99th percentile value, and we're comparing two troponin trends. One related to a chronic myocardial injury, and the other one due to an acute myocardial injury or an acute myocardial infarction. The stable, steady dashed line, blue dashed line in the center, shows you, a case where the troponin is elevated, but you really don't see that acute rise or fall pattern. Your delta is negative. There's no significant delta. This is going to tell us that we're dealing with a chronic myocardial injury. This could be a patient with chronic renal failure. This could be a patient with, a type of a cardiomyopathy that is not having an acute event. They have elevated troponin, but they don't have that acute rise or fall pattern, and therefore they're not having an acute event, as opposed to the purple line, which shows a very quick, rise and then a plateau and then a decline phase, where this is definitely tell us that there is a rise or fall pattern, and it demonstrates an acute event, an acute myocardial injury or an acute myocardial infarction. So paying attention to delta helps us differentiate these two cases, where both can present with elevated high sensitivity troponin values. So previously, whenever we had positive troponins, usually when we have positive troponins, we would have considered the patient or the case having an N-STEMI, and then we would go ahead and define whether that was a type 1 or type 2. But the fourth universal definition of MI differentiates between myocardial injury and myocardial infarction. So myocardial injury is defined as any elevation of troponin. Abnormal elevation of troponin is going to be a myocardial injury. As you see, that encompasses all ischemic and non-ischemic causes for myocardial injury. And the image on the right tells us, as you see, you could have people coming in with massive GI bleed with acute blood loss anemia. They may, release some troponin, leak some troponin. It may have an acute rise or fall pattern with significant delta. But in the absence of acute ischemic symptoms, chest pain, EKG changes, abnormal imaging, this is a myocardial injury. This is going to be an acute myocardial injury. This case does not need to be seen by cardiology unless, of course, there are ischemic signs or symptoms. They don't need to come to CACU. This could be caused by hypoxemia, by gram-negative sepsis that causes shock, by acute renal failure, by acute heart failure, by acute, tachyarrhythmias. And as long as we don't see we have no evidence of ischemia, we don't have evidence of acute myocardial infarction, new Q waves, abnormal EKG changes, ischemic EKG changes, this is not going to be an acute MI, whereas this is going to be an acute myocardial infarction. So going forward, we want to be able to differentiate between an acute myocardial injury and an acute myocardial infarction. Now, how do we diagnose acute MI? The same traditional definition applies. We need, first of all, an acute myocardial injury, which we already diagnosed by having an elevated troponin and demonstrating an acute rise or fall pattern with a significant delta. Plus, if you're able to demonstrate new ischemic changes, new ST depressions, new pathological Q waves, abnormal imaging showing loss of viable myocardium, scar on MRI, abnormal angiogram, that is when we can call an acute myocardial injury an acute MI, okay? So this algorithm kind of shows us the principles of what exactly what I mentioned so far, how to approach an elevated troponin. So you measure the troponin level in a patient suspected with ACS, and you got an elevated abnormal level above the Texas-specific 99th percentile, which was 14 for women and 22 for men. You have diagnosed myocardial injury. Now, through serial sampling, if there is, in the absence of an acute rise or fall pattern, you have chronic myocardial injury, okay? Again, this could be from renal failure, structural heart disease. You have essentially ruled out an acute event, okay? Unless the caveat is you're going to obtain history, and this just a small portion of cases, this could be due to a very late MI, a very late presenter. But other than that, what you have diagnosed is a chronic myocardial injury. However, if you're able to demonstrate a significant delta, an acute rise or fall pattern in the troponin trend, what you have diagnosed is an acute myocardial injury. Then we go and assess the patient further for any evidence of myocardial ischemia. If we find none, that will be a non-coronary acute myocardial injury. What are the examples? PE. Patient comes in with DKA. Patient comes in with myocardial contusion as a result of a blunt chest trauma. Patient comes in with aortic dissection. These are all acute events. They're non-coronary. They're not an acute MI. They're just non-ischemic acute myocardial injuries. If we are able to demonstrate these corroborative evidence of myocardial ischemia, then what we have is acute myocardial infarction. And then if there is evidence of imbalance between supply and demand, it's going to be a type 2. If not, then that's going to be our good old atherosclerotic plaque rupture type 1 MI. Going forward, diagnosing type 2 MI is going to be challenging. We have to demonstrate both evidence of ischemic changes, new Q waves, abnormal wall motion abnormalities on echo. You have to have that plus evidence of supply-demand mismatch. So let's not confuse the non-coronary acute myocardial injury with type 2 MI. Now, a quick question at this point is that what happens to unstable angina? many studies published once they review their cases of and re-adjudicate their cases of unstable angina with and without or before and after the high sensitivity troponin era. They have realized that a lot of these cases are going to be reclassified as either myocardial injury or an acute MI. Low-grade troponin levels, which we previously were not able to detect, now we're going to detect. And if you demonstrate the rise or fall, and if you demonstrate evidence of ischemia, the majority of them were reclassified as end-STEMI. But it is believed that unstable angina is still a thing. So if you're dealing with a patient who's high risk with a very high pretest probability for an ACS, good history, good story, and you will and your troponin is sort of borderline. You're not sure. Still, you can consider it as an acute event depending on the story. So unstable angina is still a thing, but the majority of what we're going to see less and less of it, and the majority of cases are going to be classified as an acute MI. Since now with the new assay, we're going to be able to detect those low-grade troponin levels. Two very important tables here. The table on the left shows a list of most common differentials or etiologies for acute myocardial injury. Of course, in addition to the 5 types of acute MI, hypertensive emergencies can lead to acute myocardial injury. Acute heart failure. We expect that the majority of patients coming in with acute heart failure are going to have some levels of detectable troponin. PE, acute aortic syndromes, dissection, cardiac surgery, cardiac interventions, ablations, biopsies, acute valvular heart disease, Takotsubo cardiomyopathy, cardiac contusion, myo or myopericarditis, and arrhythmias. Among the non-cardiovascular causes for acute myocardial injury, the most common ones you're familiar with are sepsis, acute renal failure, non-cardiac surgery, critical care illness in the critical care units, rhabdo, cardiotoxicity, stroke, even extreme exercise. And meta-analysis of professional runners showed that the majority of them had detectable or abnormal troponin levels when assessed with the high sensitivity assays. So even running can release troponin that will be detectable with our new assays. On the right, we have the table that shows us some of the more common conditions associated with chronic myocardial injury. Stable angina, chronic heart failure, in general, all cardiomyopathies can present or can lead to a chronic stable leak of troponin without any acute rise or fall pattern. Uncontrolled arrhythmia, someone who's constantly in permanent AFib, uncontrolled hypertension, chronic valvular heart disease, like I said, cardiomyopathies and pulmonary hypertension. Among the non-cardiovascular causes, CKD, ESRD, and this is very common. We constantly see our patients with ESRD coming in. They have this troponin of 0.07, 0.08, 0.07, very stable, steady, no acute rise or fall. We know that this is chronic myocardial injury. Skeletal myopathies can do this, and so do myocardial cardiotoxins. So now we get to the million-dollar question. What delta is really significant? When is delta significant? The most honest answer to that question is that we really don't know. There's no evidence-based criteria or even an approved reference range to define it, and understandably so. As you can imagine, this is complicated. I mean, first of all, the pattern of troponin rise is not linear, okay? There is a rapid phase in the acute setting, and there's plateau, and then there's the downtrend part. So it's not really linear. And the delta is going to be a function of several variables, including how frequently you're going to check your troponin. What is going to be the interval that you're going to use? Are you going to do 0 and 1 hour? Are you going to do 0, 2 hours, 0, 3 hour? So that's a variable that is important in defining delta. Also, what's the time from symptom onset and your troponin sampling? So because of these complicating factors, it's hard to come up with a delta that applies to everyone and is generalizable to all clinical scenarios. But based on the expert consensus, whenever you're dealing with higher levels of troponin, a relative change of about 20% should, raise your suspicion towards an acute event and points towards potential acute rise or fall and acute myocardial injury. Whereas when you were dealing with low level troponins, absolute values have been proposed to be used as, our cutoff to differentiate acute versus chronic myocardial injury. And that's really differs based on institutions. Having reviewed over a dozen, probably more algorithms, rapid chest pain algorithms from different institutions, I can tell you really no two are similar. And this really differs based on the delta that they have used in their algorithms are different. And that really depends on, first of all, the type of the assay they use, whether they're using a troponin I versus a troponin T. And then what clinical setting they're using. If you're using it in ED, you want to maintain a very high negative predictive value. You may want to go with, lower levels. Whereas if you're dealing with hospitalized patients who already have acute issues going on, and you expect to have some degrees of acute myocardial injury, you may decide to go with higher levels of delta to maintain some positive predictive value. It also depends on how frequently you're testing your troponin. Are you doing 0.1 or are you doing 0.3? So depending on all these situations, it varies, but we'll discuss what we're going to do here at Stony Brook. So first, let's address the inpatient setting. If you have a patient who's hospitalized and in the middle of the night they start having chest pain, first of all, how frequently are we going to check their troponin levels? It is recommended that we follow the conventional testing scheme that is 0.36 when you're dealing with hospitalized patients. And the rationale is that we don't want to risk false negatives if we test troponin too soon. If we do a 0.1 hour and then rule it out, and then the patient just starts leaking troponin a couple hours later, we don't want to risk that false negative. So the consensus is that for hospitalized inpatients, try to use the 0.36 hour protocol. And that's what we're going to do. We have not changed our care sets or care orders here in Cerner, and we have kept them as 0.36 hour. So in the inpatient setting, if you're dealing with troponin levels that are on the lower side, that is less than about 100, okay, a cutoff of 20 will tell you that you're having an acute myocardial injury, and that's 20 nanogram per liter, okay. Anything less than that, really, you look at the story, the history, the patient risk factor profile. If the delta is less than 5, you can very comfortably rule out an acute event. In the gray zone, in the between 5 and 20, feel free to order a third troponin, and you're gonna compare that to the initial baseline troponin and see if you're going to be able to detect a rise or fall pattern. So remember a delta of 20 for low-grade troponin levels. For troponin levels more than 100 to 150, and if you remember, we said this is going to be equivalent to a conventional troponin of 0.1. For these relatively high levels of troponin, a relative change is recommended. That's what we're going to use at Stony Brook, and we're going to define that delta as a rise of 20%. Okay, so if you have a 20% rise in your initial troponin on serial sampling, then that indicates an acute myocardial injury. So 20 and 20%. Now let's shift to the emergency department. This is the area where the most enthusiasm about transition to high sensitivity assays really come from. This is where we are really able to take advantage of the high sensitivity, which translates into a great negative predictive value. This leads to earlier detection, rule in and rule out of acute MI. The literature, the rate of success really, what they report is variable, but on average, we expect a reduction in AD length of stay by 20%. That's what has been, described and reported in the literature. An amazing single troponin draw method or a 0-hour rule-out method has been used very successfully for immediate and safe disposition of patients, low-risk patients with chest pain, which has led to quick discharge of up to 50% of these patients, provided they come in at least 3 hours after symptom onset. So a low-risk patient, low pretest probability, comes in, has had chest pain for at least about 3 hours, or the symptom onset was 3 hours ago. Quick troponin draw, and if it's negative, you send them home. And this has been a very, safe method of risk stratification. And we are going to apply this method here in our ED. This table, I took it from the recent publication, the 2022 ACC Expert Consensus on Evaluation and Disposition of Patients with Chest Pain. So it shows you there are different methods. Different EDs can decide to use the 0-3 hour, the 0-1 hour, 0-2 hour. There's literature that there's really no difference, and 0-2 hour was non-inferior to 0-1. And if honestly, if we can use the 0-1 hour and use the high sensitivity of this assay in our advantage, why not? So, and that is what we're going to do here at Stony Brook. And this is another algorithm from the same document. And what it's trying to say is that you may look at different algorithms from different institutions and see that there are differences. Some do apply and use risk scores for further risk stratification. Some, such as Mayo Clinic, only rely on troponin. And that is fine. They're all really relying on definitions, on principles outlined in the fourth universal definition of MI. And the whole purpose is really to risk stratify the patients to a low risk or rule out group where you can safely discharge and have them follow up as outpatient, or to a high risk group where you have diagnosed an acute myocardial injury. You still have work to do. Again, this does not mean they have to go to cardiology. You assess them for evidence of ischemia and see if the acute event is an injury or a true MI. And also to the intermediate risk group. So so the whole principle is to risk stratify the patients into these three groups. And this intermediate risk group is the one that you can keep and quickly do a CTCA or do a bedside ultrasound or send for a stress test for further risk stratification. This is just meant to show you what principles we're following with all these rapid chest pain algorithms. The point from this important image figure that we're trying to say to get is, let's look at it. The y-axis is telling us what the troponin concentration is, and as you see, with the high sensitivity troponin, it can range from 5 or 6 to up to thousands. Okay, so I want you to pay attention to the positive predictive value for the MI. As you can see, with troponin levels in around 50 up to 100, your positive predictive value is sort of low for acute MI, for diagnosing an acute MI. And more likely, patients who come in with this troponin levels are having other conditions, or might be experiencing myocarditis, Takotsubo, pulmonary embolus, heart failure, shock, hypertensive crisis, or many other. Really, the differential diagnosis is much broader when you're dealing with low levels of troponin. And as the troponin level increases, and when you get to the levels where we're dealing with, thousands, that is when really we get a really good positive predictive value for an acute MI. And this is what we need to keep in mind dealing with, when assessing patients with ACS who have abnormal troponins, especially going forward in the high sensitivity troponin era. So this is our ACS risk stratification protocol that we are going to use here in the ED. I know we can't read it, so that's why I broke it into pieces. So this is the first part. And again, we are following the same principles that have been outlined elsewhere. We quickly triage the patients. And of course, when you're dealing with a patient with ACS, if you see those high-risk features, if you're seeing ST elevation or STEMI equivalent, at our institution, that's the STEMI call. That's a code H. Going forward, you have started assessing the patients with an EKG and a baseline troponin. If based on your initial assessment, you see a relatively high troponin, this is the value, the anchor value that we discussed, equivalent to a current troponin of 0.1. If you encounter this, there is a good chance that your patient is experiencing a real acute MI or an acute event. If you see high risk or dynamic changes, if your patient comes in, with Valentine, if you are a fan of, risk scores and use it, and you get a very high heart score, it is reasonable to contact cardiology early. And that's what the system we have in place is the heart alert. Okay. If you have none of this, then we go to the next phase. You send the second troponin at 1 hour. So 0 and 1 hour, that's the protocol we're going to use. And based on a delta of 5, you're going to risk stratify your patients into the rule-in zone on the left, to the rule-out zone on the right, and the observation zone or the gray zone, which is in the middle. So for the patients who are ruled in, what you have diagnosed in ED is an acute myocardial injury. Okay, we have recognized that the patient has an elevated troponin, and the delta suggests a significant rise or fall pattern. So we have an acute myocardial injury. Now, based on our clinical judgments, we see what's going on. Is this a PE? Is this a myocardial contusion? Is this a dissection, or is this a real MI? Okay. And based on that will help us in terms of the dispo. In the rule out zone, you can either go ahead and discharge the patient, but this would be better to apply a risk score, such as heart score, and the low risk individuals can be safely discharged without patient follow-up. The intermediate risk, you can consider doing a C2CA or like a quick ischemic eval, or even just putting a, bedside echo probe on them. And then based on that, you can decide on whether to keep them or send them out. The gray zone, or the neither rule in or rule out zone, or the intermediate risk zone, it's recommended to send a third troponin. So our pattern is going to be 0, 1, 3, and we're going to compare the third troponin with the baseline, with the 0-hour troponin. And based on these proposed deltas, again, we're going to risk stratify the patients. We can apply the heart score to identify those who are at extremely low risk, and they can be safely discharged, quickly discharged to go home and follow up as outpatient, versus the ones that we want to keep and ideally do some further testing. We are also going to apply the single troponin draw method for low-risk patients, heart score less than 3, and those who the time from symptom onset has been at least 3 hours. A single troponin draw can lead to a safe and effective discharge of these patients with outpatient follow-up. So we look forward to implementing this algorithm in our ED. And of course, we keep an open mind. We assess, how things go, resource utilization, and we are always happy to revisit this and make, minor changes if necessary. So we would love to receive feedback from colleagues after this really goes live. This diagram is something we are doing. It just helps us sort of determine what workup we do for those patients who are determined to be in the intermediate risk group. You might want to grab an echo probe and do a bedside echo, assess for any signs of, acute ischemia, myocardial, ball motion abnormalities. Or if you want to do a non-invasive ischemic eval, you want to choose between a stress test or versus a CTA. This is what we currently do. If you have a patient who is tachycardic, who has severe contrast allergy, renal failure, or has known CAD or stents, you prefer not to do a CTA, of course. You prefer to do stress testing. If there's a patient whose body habitus prevents them from having a quick one-day stress protocol, and they have no known history of CAD, they're on the low risk side, you may want to decide to do a CTA. So this really differs based on the clinical scenario and a lot of factors, but it's just meant to be a guide to help our colleagues, come up with a strategy for non-invasive ischemic evaluation. This is the heart score. We are familiar with this. Again, having reviewed many protocols from many different institutions, some have decided to go with various, risk stratification and risk stratification protocol risk scores, such as heart score. Mayo Clinic doesn't. They only go based on troponin, but many other institutions actually do incorporate risk scores, such as heart score, in their in their algorithms, and there's really no right or wrong as long as we all follow the principles that we all agreed upon and are outlined in the first universal definition of MI. We really can't go wrong. Just a quick slide about non-cardiac surgery. Currently, based on the guidelines, and this is nothing new, the guidelines recommend against routine sampling of troponin after a non-cardiac surgery. And we know that after non-cardiac surgery, we expect a good proportion of patients to have up to 20%. And with high sensitivity troponin, we expect that percentage is only going to go higher. It's going to be more. We expect these patients to have positive and abnormal troponin levels, and that is called post-op myocardial injury, or PMI. The majority of these patients are not going to have any ischemic signs or symptoms, no chest pain, no EKG changes, and no new abnormal imaging findings. So really in the absence of, we don't have any guidelines to tell us what to do with this troponin and how to handle it and what interventions to do to improve patients' outcomes. So because of this, and to prevent any confusion that might come from the interpretation, any challenges that might result from this abnormal troponins, the current guidelines recommend against routine sampling of troponin in post-op patients. So we're not going to do it unless there is a good, legitimate reason to think patients going through an ACS, in which case we will proceed as per guidelines. So just to summarize what we've already said, we all want to make sure that we survive this transition to high-sensitivity troponin and be able to enjoy, all the perks and all the positive aspects of it to facilitate triage of our patients in the emergency department. And this is, none of this is really new. We have been doing this. We know all these principles, but I just want to reiterate that we only order troponin when we really suspect a myocardial ischemia, myocardial infarction. We never routinely just randomly order troponin for screening. It would be helpful to learn to translate, especially initially, to translate the fourth generation troponin with the fifth generation troponin with the new high sensitivity assay values. And that's, the literature shows that helps sort of, curb or to some degrees prevent that initial psychological shock from seeing really large troponin values. So to review the table that I put in, and we're going to share these slides with everybody, to review and make sure that you're familiar and comfortable with this translation. And again, as always, when interpreting elevated troponins, we look at the patient as a whole. We look at the entire clinical scenario, the pretest probability, what are the risk factors, what does the EKG show, if there's imaging data available, we review that. So we never judge, we never diagnose MI solely based on the troponin level. We need to look at everything and all these corroborative evidence to determine if someone has an MI or an acute MI or not. Pay more attention to delta or to this rate of rise or the change between consecutive troponins. Once you determine a patient has chronic myocardial injury, you're done. They don't have an acute event. They definitely don't have an acute MI, but of course the history is important. And review the differential diagnosis of acute and chronic myocardial injury. This comes very handy in ED when you're really not sure that your case of acute myocardial injury, is this due to an acute MI or not? What else could be causing it? What else could explain what you're seeing on the troponin trend? And be aware that the vast majority of the newly identified, with the new assay, we're going to see again, remember that gray zone that I showed, we're going to see a lot of patients having troponin in that area. Just, be assured that the vast majority of those patients are not going to be an acute MI. So again, paying attention to these principles help us differentiate them from patients who are having a quick doubling or tripling troponin on their trend. And hopefully we can effectively and efficiently differentiate acute myocardial injury from myocardial MI. And finally, cardiology consult team is always available to help. We don't want to overwhelm them. We don't want to bombard them with, we don't want them to consult on every elevated troponin. So we ask everyone to, apply all the principles that we discussed. But whenever you need help, if you're not sure, if you really suspect that your patient's suffering from an acute ischemic event, we are always available to help. So feel free to reach us. You might want to consider sort of an early cardiology consult if you're evaluating a patient with signs and symptoms of ACS, and if their initial troponin is on the higher side, that is more than 100 to 150. Okay, if you have very high risk EKG findings, again, you want to call us early. If you have elevated troponin and you're seeing a significant delta, doubling, tripling on the trend, and your patient is, of course, having chest pain, call us early. If you have a patient where the pretest probability is very high, they're a very high risk individual, they have a good story, and they have ongoing chest pain, but their delta is sort of borderline and you're not sure on the fence, there is a good chance that, again, pretest probability is extremely important. There is a good chance they're having an acute event, and this is serious. And if you're a fan of risk scores, and if your patient is having a very high heart score and they're symptomatic, again, that is reasonable to contact cardiology. This final slide, last but not least, and it's actually is a very, very important slide. So I know towards the end of my talk, but I really want to ask everyone's attention on this. Colleagues from cardiology and medicine and non-cardiology clinicians. Describing and again, as we said, we expect to see a lot of, low-level, mild troponin leak that, is not going to be due to acute MI. How do we describe or document this? This is extremely important. I cannot emphasize how important this is, the part that I'm going to discuss and share with you. The table that you see in the middle is a case that was discussed, was sent to us just a couple of days ago, and we receive these not infrequently. We really want to, and this is a matter of our quality metrics, okay? We want to, when we describe or document mildly elevated troponin levels, we want to avoid terminology that, if we decide that this is not an MI, we want to avoid terminology in documenting that could imply a diagnosis of MI. Because, of course, this is going to, get coded as a complication and unnecessarily is going to affect our quality metrics, and we want to avoid that. So this is a patient, and I hopefully have successfully de-identified them, who had a vascular surgery in December. They come back within 30 days with a completely unrelated complaint. They're admitted with shortness of breath due to COPD exacerbation and AKI. Okay, so the house staff assessing the patient reviewed the troponin. They determined that it was a low-grade troponin elevation, that there were, in the absence of any symptoms, signs and symptoms of ischemia, this was not an acute MI, and this was really due to the shortness of breath from COPD. They correctly made that diagnosis. However, when they documented this, they said demand ischemia. Unfortunately, the term demand ischemia, which we all use and have used for years, automatically gets translated into a type 2 MI, which is still an MI. Okay, so this gets coded as a post-op MI. This patient has been coded to have a post-op complication, having an acute myocardial infarction, which clearly is not the case. Okay, so the only way to first of all, avoid this is to really pay attention to how we document these cases. And in the absence of clear evidence of myocardial ischemia, the best approach is just to simply describe what you're seeing. There is troponin elevation, unlikely due to ACS, but most likely due to hypoxemia in this case, or viral bronchitis, or tachycardia, or in other cases, acute anemia, sepsis, PE, or whatever, the clinical scenario is. And that is absolutely okay. But using terminology such as, type 2 or demand ischemia, I really want to ask everyone to just retire the term demand ischemia, because that automatically, gets translated into an acute MI and really unnecessarily affects the quality metrics. And MI goes into the hospital readmission statistics, the post-op, the NSQIP, the National Surgery, the database that monitors and tracks these post-op complications. It gets coded as a complication in those databases. And we really want to avoid that because that's absolutely unnecessary. Again, here in this example, the house staff clinically determined that this was not a case of an acute MI, and just, the terminology we use to describe and document it is important to avoid negatively affect our quality metrics. So I hope that, this is clear, but I'm happy to answer any question that comes about this, and we'll continue to educate the house staff about this. This patient is going to get a cardiology consult, a cardiology fellow, on top of their other 15 consults that they have to see. They may have to see this patient just to clarify that this patient actually does not have an acute MI. And these cases can be prevented by a more accurate documentation of these, mildly elevated troponin levels due to non-coronary acute myocardial injury. Okay, I think that this is what I have here. I have a list of recommended resources that have discussed transition to high sensitivity troponin, what to expect, how to be prepared for it. And I do recommend, if you have time, to review them. These are really good resources, and I've listed them here. They'll be made available to you. And with that, I thank you for your attention. I think that with our educational campaign, we can, get everyone ready and on board for our transition that we expect to launch in mid-February. I'm happy to answer any questions from the audience.
So that was absolutely just spectacular. I can't tell you, on behalf of everybody in the institution, I think that this is just definitive, and it really clarifies a lot of different areas. I will open it up to our group. I see that Tamid wrote fantastic talk and review. Do we see changes in high sensitivity troponin with CVA?
With CVA, you mean with strokes? We do expect to see a lot of mildly elevated troponins, again, in that gray zone or around 50s to less than 100. With patients with stroke, if you trend the troponins, it may even look like there is an acute pattern. But again, in the absence of ischemic signs or symptoms, if your patient's not having a chest pain, if your patient's not having ischemic EKG changes, we attribute to an acute myocardial injury from their stroke and not from an acute MI. If I didn't answer your question, I'm happy to discuss it, further after the meeting as well. No,
that was perfect. I see that Dr. Kokosis also wrote, and I know there's a huge amount of sensitivity and disinformation, especially in the perivascular procedures, as you showed just earlier. But she wrote, does acute myocardial injury code the same as infarction? And if so, do we really need to get rid of that concept and, as we're writing, and really just write troponin elevation secondary to, and then show the proximate cause?
Excellent question. We really emphasize on the wording, on the semantic, on how we put this and how we describe this. To my knowledge, the coding is not the same. I can clarify that. But really the best approach, as you said, is just to simply describe what we are seeing. And honesty is always the best approach. Just to say the troponin elevation likely due to tachycardia, blood loss, hypoxia, and likely not due to an ACS. And that would be perfect. It will not code it. This will not be coded as an acute MI.
And maybe this is best directed towards Dr. Lawson and Dr. Rahman. Is there a monthly review of elevations in troponin and which ones are being correctly coded and not incorrectly coded on a monthly basis?
For the post-op ones, yes, I know that, there's a group that, they're reviewing the troponin elevation and how it's being documented and, of course, coded. If you mean for the entire hospital, for all troponins, I'm not aware of that.
Michael Tao, I see you have your hand raised.
Thanks for that comprehensive review, Dr. Dianati. I just had a question. So I saw there's been some studies looking at the impact of hemolysis on the high sensitivity Trop assay. Do we have any way of like adjusting for that, or how we can interpret it if it's been hemolyzed?
Excellent question. So we expect very rare false positive and false negatives for the current assay, and one of the very rare reasons for a false negative will be hemolysis. But the lab knows, and if they receive a hemolyzed sample, they will not process it. So you should technically not. We should not be concerned about hemolysis. They will ask for a new sample to be processed. If the lab receives a hemolyzed sample, they will not run the assay on that sample. Another rare reason for a false negative, by the way, is using mega doses of biotin, which might be important in obtaining history. But again, these are extremely rare scenarios.
I see one of our coders extraordinaire, Sandy Mayer, put into the chat box. There are separate codes for myocardial injury, which is I51.89, and NSTEMI type 1. I-214. Dr. Gavalis?
Yeah, thanks. Neda, that was a really great talk, really comprehensive, and thanks for doing all that work to inform us and educate us. Question about patients who are diagnosed with acute or chronic myocardial injury. Is there any, and if they're not going to get any kind of invasive procedures, is there any mandate or recommendations or like requirements from the perspective of being discharged on certain medications? Are these patients needing to be on aspirin, on beta blocker, on statin? Is there some gray zone? Is there certain that they should be on of those? What's kind of the consensus with that?
Mike, that is a great question. I mean, even for type 2 MI, there is really no consensus of, I mean, we try to treat them based on the risk factors, but do you really treat them like a type 1 MI or no? There's question there. With acute myocardial injury, the same. We don't want to really trivialize a positive troponin. We know whenever there is troponin, we know any troponin is worse than no troponin. And we know that people who leak troponin with various non-cardiac, non-coronary conditions, they are at risk of, there is a prognostic, importance there. And that we know that they're at high risk of 30-day events compared to those who come in with the same issues and they don't leak troponin. But we don't have really guideline-directed, evidence on how to treat these. Like, do we treat them like an MI? We don't know that. We don't have that direction. But I expect that we will, they are looking at it, and we will have some information in the near future. At the moment, we don't have a guideline-directed therapy for someone who comes in and develops an acute myocardial injury from, say, acute blood loss anemia. We don't have that, but what I think most cardiologists do is that at some point, once these patients stabilize as outpatient, we want them to be evaluated and their risk factors addressed and potentially even tested. But to answer your questions, whether there is a guideline-directed therapy for these patients to treat them, we don't have that yet.
Right, and not something that's going to be, the patient's discharged not on a beta blocker, not an ACE inhibitor. That's not going to affect outcomes, metrics, or things of that nature.
No, I mean, we go based on our clinical judgment. If they need beta blockers for whatever reason, yes, we give it to them.
Yeah.
But no, we're not going to be judged or dinged for not giving, an ACE or ARB to a patient who came in, developed some troponins, no.
Okay, thanks.
And I think that question should extend to the one that Dr. Bloom asked, where she said, how can we code for troponin leak in the setting of acutely decompensated heart failure, and trying to get away from those terms like troponin leak and just say troponin elevation secondary to.
Yes, troponin elevation secondary to an acute, acute heart failure, which does not seem to be due to an acute ACS or an ACS. And I believe, leaving at that is very descriptive and, exactly is a very honest description and should not cause any coding issues.
Continuing in the heart failure realm, Dr. Jang asked us, What about the elevations that you see with myocarditis and the fact that sometimes there might be a little bit of a delta associated with acute myocarditis? How do you think we should best handle that?
Well, exactly. Myo and myocarditis, one of the etiologies that we discussed of acute myocardial injury, non-coronary acute myocardial injury, and we expect that. In terms of documentation, we documented exactly as is, that, in the absence of evidence of ischemia, this seems to be due to an acute inflammation or due to a myocarditis. That takes care of the coding issue, and otherwise we treat the patient as per guidelines.
And I will leave the last question to Dr. Kane.
Hi, can everyone hear me?
Yes.
Thank you, Neda. Thank you for that talk. Very comprehensive review of everything. Just one question that came to mind in the past. We've used CK or CKNB. Now that we have the high sensitivity troponin, does that kind of obviate that need to look at CK anymore?
It is really not recommended to compare or to do both. Currently, we're shifting, and high sensitivity troponin is turning into the standard of care. And really none of the guidelines recommend that you check both. CK, you look at if you're, to my knowledge, if I remember well from medical school, if you're looking at myopathies, skeletal myopathies, rhabdo, things like that. I mean, we definitely check the CPK, but in order to diagnose ACS, in the high sensitivity troponin era, I don't think there's a role for CK or CKNB anymore.
Yeah, being one of the older people, I do remember we used to say because CKMB had a longer half-life, that you got more of a sense of how large the MIs were by the area under the curve of the MBs if you got multiple. Clinically and practically, we don't use that anymore. And really, I think rhabdo might be the exception of where you're looking. Neda, I cannot begin to thank you. The amount of time and effort and the speed with which you got this done, and that really just was a perfect presentation. So on behalf of everybody, thank you.
Thank you, everyone, for your attention. If, other questions, concerns, you know where to find me. So I'm happy to address anything even afterwards. Even after we lunch, you can find me, and I hopefully can address concerns and questions. Have a wonderful Thursday, and goodbye.